Thank you for participating in this meeting, and I am honored to be part of the memorial lecture of Dr. Chog, the father of nephrology. And I really enjoyed the lectures by Dr. Gupta and Dr. Samaniego, mixed rejection and late antibody-mediated rejection treatment. So to switch gear, since over the past 9 months, everybody's talking about virus. So, and we as a transplant community, we have a lot of viruses to talk about. So I meant to make my presentation about one of viruses called, everybody knows, the BK virus and what's new about the treatment for BK virus. So as a background, BK virus is a polyoma virus, a subgroup of the papova virus. And infection typically occurs during childhood. The virus remains latent in the uroepithelium, and the serological prevalence of this virus in the general population about 80%. And when the immune system gets suppressed, this virus flares up. As of now, there are 13 strains have been found for in this family. And just as a contrast, we have the COVID-19, which the case index was presumably in China. The BK virus is an older virus discovered in 1971 by Dr. Gardner, and the case index was a Sudanese patient. And that's how the name came from, the initials of this patient name. Briefly, we know the risk factors for BK infection and the BK virus nephropathy could be related to donor factors, recipient factors, or transplant factors. And in a nutshell, basically, whether directly or indirectly, these factors can lead to more immunosuppression and flaring up of the virus. And as we know that the BK virus as well as the CMV virus have significant impact on the graft survival. Definitely this is a concern for any transplant nephrologist. So as a general landscape for the treatment of the BK virus, the gold standard is reduction of immune suppression. Several studies showed maybe some efficacy of leflunomide. Other studies showed the fluoroquinolones, the cidofovir as well. At some point, brencidofovir was contemplated to be a new agent. However, it didn't pan out. We use immunoglobulins. And most recently, since the TRANSFORM study using everolimus, we actually adopted this in Cleveland Clinic in the past 2 years using low or no calcineurin inhibitors with everolimus and steroids. And actually, our own experience is that most patients had a decline in BK viremia. And in fact, almost 50% of patients had reversed their BK nephropathy with biopsy-proven BK nephropathy had reversed in subsequent biopsies to normalization. Now, as a background, we found out that the cellular immune response has an important role in the BK virus replication. And that was demonstrated in several studies showing an increased risk of high level of BK viremia, whether due to a low CD4 T cell count or decrease in release of cytokines and interferon by the T cells, or a lower number of BK virus specific CD8. So it seems to be more intuitive that maybe this is a new target for treatment for the BK virus by using T-cell treatment. So in fact, the virus-specific T cells, which basically are generated by repeat stimulation with the antigen-presenting cells expressing viral antigens. And most data are coming from stem cell transplant scientists. So back in the late 2000s, virus-specific T cells were developed from stem cell transplant donors, and it showed efficacy in the treatment of CMV, EBV, and other viruses. The only concern was back then was the development of graft versus host disease, and concern was minimized given the low incidence of graft versus host disease. So one of the points that led to more evolution in this process is to use healthy donors, which we call them third-party donors who have immunity, and use them as a source for banked T cells. So again, these are hematopoietic stem cell transplant recipients. So two studies have shown the effect of this third-party donor or coming from healthy donor with immunity using their T cells to treat viruses. So the first study was called Shala. They used bank T cells, and this was used for adenovirus, CMV, and EBV. It showed a very good clinical response and virologic response, and so in very few cases of de novo graft versus host disease. So basically, this showed proof of concept that T cells could be effective for treatment of viruses. The concern was that certain modifications have to be done to reduce the potential risk of infection from using the T cells, to streamline the process of manufacturing, enhance the T cell expansion and potency, and reduce the time for manufacturing, and maybe expand the number of viruses that can be treated by the T cells. And that led to another study called CHARM study. Again, these studies were done in stem cell transplant patients. The second study was done, I think it started back in 2016, but the preliminary results have been published in Journal of Oncology. And basically, the CHARM study was a phase 2 clinical trial using virus-specific T-cell lines from healthy seropositive donors, what we call off-the-shelf. And one of the antigens they used against is the large T antigen and the VP1 antigens in the BK virus. The selection was based on some HLA matching between the recipients and the third-party donors. So the preliminary studies were published in Journal of Clinical Oncology back in 2017, and that was very promising. So the CHARM study, they had 54 suitable virus-specific T-cell lines. They were able to treat 38 patients, and 16 were not eligible due to severe sickness. 31 patients were treated for a single virus, and 7 were treated for at least 2 viruses. Some of the patients did require multiple infusions of the T cell. This table showed that among the recipients, patients who were recruited in this study, the majority had CMV and BK virus, which were, they are the most common viruses we have in kidney transplants. And design was to inject, it's an infusion using these virus-specific T cells. Additional infusion doses can be administered, and monitoring patients for the viral load, the graft versus host disease, uh, liver toxicity, infusion toxicity, and other lab tests. So the results of this CHARM study were very promising. So 16 stem cell transplant patients with BK hemorrhagic cystitis and BK biopsy-proven BK virus nephropathy did show improvements. So all patients actually showed clinical benefit, and there was decrease in the urinary viral load for the BK up to 96% by week 12. Even the 2 patients with biopsy-proven BK nephropathy did respond to this treatment with improved renal function. So in this paper, they have not shown the decline in the BK virus in the serum. However, they showed that the degree of hemorrhagic cystitis in those patients did significantly improve with the treatment. And they even showed that one of the patients had a big blood clot in the urinary bladder due to hemorrhagic cystitis, and that decreased significantly after the treatment. In the study, they also showed that the virus-specific T cells were also effective against the CMV, EBV, adenovirus, and human herpes virus. So they showed that how most patients had a decline in their viral load in the serum. So what about the kidney transplant? So that's actually one of the upcoming clinical trial sponsored by a company called Allovir. And this is a trial that the Cleveland Clinic is going to participate in. And basically it's a phase 2 multi-center randomized double-blind placebo control and the goal is to show the safety, tolerability, and effectiveness of the adoptively transferred virus-specific T cells in kidney transplant recipients with BK viremia. So we're very excited to participate in this study because it might be an opportunity to find a way to treat patients with BK viremia and hopefully as well to the CMV. So as I mentioned, this study will be coming up. It's the long period of follow-up. It's 99 weeks follow-up, and patients will receive infusions of virus-specific T cells and with a controlled group receiving a placebo. And the patients will be monitored definitely for the BK viral load, the renal function, immune function, and whether any modifications in their immune suppression. So how can we, as a transplant nephrologist and as a nephrologist in general, help in this pandemic? So actually, there are studies showing that the COVID-19 patients have significant T cell deficiency. And this is a courtesy of the Allovir company that showed that, yes, patients who are really having significant deterioration in their clinical condition requiring ICU admission with positive COVID-19 had a significant lower T cell count compared to healthy population. And that's exactly what they have shown, that using virus-specific T cells for the COVID-19, and the term the bench name is Allovir 109, showed that this virus-specific T cells does have a significant cytolytic activity against the virus and may be a promising role. And in fact, they had a green light from the FDA to show the proof of concept that maybe virus-specific T cells can be helpful in treating COVID-19. and hopefully will show that the virus-specific T cells can help also treating BK and CMV in transplant patients. In the interest of time, I thank you, and again, I'm honored to participate in the memorial lecture of Dr. Chobe.